talking about the HCRN GU16 to 60 trial, which was a phase 2 trial of Nivo monotherapy followed by Nivo Ipi boost in patients with clear cell metastatic kidney cancer. And the clinical results of this trial were published in Journal of Clinical Oncology in April of 2022. And what I'm talking about at this meeting is the results of a correlative analysis looking at treatment-free survival in this study. And what we've known for a while is that immune therapy is unique in that patients can have durable control of their disease after treatment stops. And they also sometimes can experience toxicities that persist after treatment stops. And treatment-free survival was developed as an endpoint that could look at what goes on during that treatment-free period. And we've looked at this in other studies in patients with melanoma and kidney cancer using immune therapy, but those studies were compromised because the treatment was only stopped for toxicity or disease progression, and there was no defined treatment endpoint. So we wanted to look at that in this study because treatment stopped at a maximum of about 96 weeks and see how that influenced treatment-free survival. So we have updated this study through 37.7 months and looked at a 36-month period for the 128 patients enrolled. And we defined treatment-free survival as the area between two time-to-event endpoints. The time from treatment study registration until treatment cessation, and the time from study registration to starting subsequent therapy over a 36-month period. So when we looked at the updated clinical data, we saw when we wanted to combine Part A and Part B in the study into one regimen, we saw the overall response rate was 36%, 58% in the favorable risk population, 27% in the intermediate and poor risk population, 68% of all patients were alive, and 38% of patients were alive without having begun subsequent therapy, and all patients had finished treatment. And so when we looked at that 36-month time frame, we saw that for the average patient, 30 months of that 36-month time frame was spent alive, and those 30 months were divided into time on treatment, 11.5 months, treatment-free period, 9.5 months, and time on subsequent therapy, 9 months, adding up to 30 months. And when we looked at it for the favorable risk patients, we saw that treatment-free survival period was 12.9 months, or 36% of that total 36-month period, and that 99% of that time was spent alive. There was only one death in those favorable risk patients, which occurred at 28 months. While in the intermediate and poor risk patients, treatment-free survival represented about 22% of that 36-month period. When we compared those results to the results of CheckMate 214 on the Ipi-Nivo arm, the treatment-free survival compared favorably, illustrating the value of having a treatment cessation endpoint. We feel that treatment-free survival is a valuable endpoint that contributes meaningful data to clinical trial beyond what is captured with traditional endpoints. And therefore, we think it's something that should be considered in all immunotherapy trials, and potentially all trials, not just in kidney cancer, but potentially other diseases. And the second point that I think came from this study was how well the favorable risk patients did, both in terms of overall survival and treatment-free survival, supporting the notion that there should be an immunotherapy-only arm or treatment approved for that patient population.